Excellence in healthcare education and delivery has been the hallmark of this institution since its establishment in 1911. Today, we delve into the intricate realm of the thoracic spine and chest wall, a subject of paramount importance for medical practitioners. Our learning objectives for this session are multifaceted. First, we aim to equip you with the knowledge and skills to recognize, diagnose, and manage the complex condition of thoracic myelopathy. Additionally, we will explore the nuances of differentiating thoracic radiculopathy from castivertebral sprain or strain, a distinction crucial for appropriate treatment. Furthermore, we will delve into the realm of scapular dyskinesia, focusing on observational techniques and diagnostic approaches. Vigilance is key, as we will also discuss the identification of dermatologic lesions, including the telltale signs of herpes zoster and various carcinomas. Finally, we must remain mindful of the potential for pulmonary emboli, a critical consideration in thoracic pain presentations. Before we proceed, I invite you to ponder the following question: what pathologies can be the cause of thoracic pain? Take a moment to reflect on this query, as we will revisit it after exploring additional slides. When encountering a patient presenting with thoracic pain, a comprehensive history is essential. The questions we pose can unveil crucial insights into the underlying condition. Let us explore the inquiries we should consider and the rationale behind them. The traditional history-taking process should encompass the location of the pain, its onset, and the mechanism of injury or onset. Employing scales such as the visual analog scale, verbal analog scale, or numeric rating scale can aid in quantifying the patient's pain experience. Furthermore, inquiring about factors that exacerbate or relieve the symptoms can provide valuable clues. The age of the patient is a significant consideration, as certain conditions may be more prevalent in specific age groups. For instance, age-related osteoporosis can predispose individuals to compression fractures, a potential cause of thoracic pain. 6. Several additional lines of questioning can shed light on the patient's medical history and potential risk factors. Inquiring about corticosteroid use is crucial, as long-term corticosteroid therapy can lead to osteoporosis, increasing the risk of compression fractures. Exploring the patient's history of cancer is equally important, as metastatic lesions may manifest as thoracic pain. Similarly, a known history of autoimmune disorders, such as ankylosing spondylitis or rheumatoid arthritis, can contribute to spinal pathologies. Investigating a prior history of herpes zoster is essential, as this viral infection can lead to postherpetic pain, a persistent and debilitating condition. Recent surgical procedures, or a history of thrombosis, may also increase the risk of pulmonary emboli, which can present with thoracic pain and shortness of breath. Finally, inquiring about urinary frequency can reveal potential myelopathic symptoms, indicating the need for further evaluation. Let us now delve deeper into the rationale behind some of these inquiries. A history of corticosteroid use is significant because indiscriminate, long-term use of these medications, while less common today, can lead to osteoporosis. Corticosteroids are catabolic steroids, meaning they can promote bone breakdown and weaken bone structure. Prolonged use can predispose patients to thoracic compression fractures. Additionally, corticosteroids can elevate serum glucose levels and cause fluid retention, factors that may impact the patient's overall health and management approach. While a few epidural steroid injections are unlikely to cause systemic osteoporosis, they can affect serum glucose levels in patients with diabetes. This is because corticosteroids can temporarily increase blood sugar levels, necessitating close monitoring and potential adjustments to diabetes management. A known history of cancer is a critical consideration, as metastatic lesions can cause thoracic pain. In such cases, it is imperative to determine if the patient has metastatic bone lesions before proceeding with any interventions. Diagnostic tests, such as full-body bone scans or MRI scans of the affected area, can reveal the presence of metastatic lesions, guiding the appropriate course of action. If metastatic lesions are suspected or confirmed, utmost caution must be exercised during physical examination, manipulation, rehabilitation, or mobilization techniques. Applying excessive force or pressure in the presence of metastatic bone lesions can increase the risk of pathologic fractures, potentially exacerbating the patient's condition. For patients with a history of cancer, it is crucial to inquire about their current care team and treatment plan. If the patient is under the care of an oncologist, it is essential to coordinate and collaborate with the oncology team to ensure a comprehensive and integrated approach to pain management and overall care. Additionally, some patients may seek complementary therapies, such as acupuncture, which has been shown to effectively reduce or alleviate chemotherapy-induced nausea. While acupuncture can be utilized throughout the course of care, herbal remedies should be discouraged during chemotherapy, as they may interact with or negate the effects of the chemotherapeutic agents. Inquiring about a known history of autoimmune disorders is also important, as conditions like ankylosing spondylitis, rheumatoid arthritis, Scheuermann's disease, or diffuse idiopathic skeletal hyperostosis, DISH, can contribute to spinal pathologies and thoracic pain. A history of herpes zoster, commonly known as shingles, is a critical consideration. The thorax is a common site for this viral infection, but it can also occur in other areas of the body. Even after the herpes zoster vesicles disappear, patients may experience postherpetic pain, a persistent and often debilitating condition that can last for years or more. While various medications, topical treatments, nerve blocks, botulinum toxin injections, and spinal cord stimulators may provide some relief, the management of postherpetic pain remains challenging, particularly in elderly or immunocompromised patients. It is essential to address and manage acute herpes zoster outbreaks promptly, as we will discuss later in this presentation. A history of recent surgery, particularly major surgical procedures, can increase the risk of thrombus formation. Thrombi, or blood clots, can subsequently lead to the development of emboli, which can travel to the lungs and cause pulmonary emboli. The symptoms of pulmonary emboli, such as thoracic pain, muscle spasms, and shortness of breath, can mimic those of thoracic spine pathologies, making it crucial to differentiate between the two conditions. It is worth noting that the Centers for Disease Control and Prevention, CDC, limited the use of the Johnson & Johnson COVID-19 vaccine on May 5, 2022, due to concerns about thrombus formation associated with this particular vaccine. However, the Johnson & Johnson vaccine remains recommended for individuals who cannot receive the Pfizer or Moderna vaccines. For patients with a known history of thrombus, the risk of developing emboli, including pulmonary emboli, is heightened. As mentioned earlier, pulmonary emboli can manifest with thoracic pain, muscle spasms, and shortness of breath, which can be mistaken for thoracic spine pathologies. In cases where pulmonary emboli are suspected, it is imperative to observe the patient's respiratory status and check their vital signs, including pulse oximeter readings for oxygen saturation, respiration rate, blood pressure, and temperature. These vital signs can provide valuable insights and aid in the differential diagnosis. Urinary frequency can be a symptom of myelopathy, a condition affecting the spinal cord. However, this symptom should be accompanied by other myelopathic symptoms and an appropriate medical history to be considered indicative of myelopathy. It is important to note that urinary frequency can also be caused by other conditions, such as benign prostatic hyperplasia, BPH, prostate cancer, or urinary tract infections, UTIs. During the physical examination, it is crucial to perform a comprehensive assessment of reflexes, regardless of the patient's presenting complaint or suspected pathology. This practice should be consistently applied to all patients, not just those with spinal conditions. Assessing reflexes can provide valuable insights into the potential involvement of the thoracic spine. Can you recall which pathologic reflex should be present if the pathology is indeed in the thoracic spine? During the physical examination, it is imperative to be observant for any dermatologic lesions, such as herpes zoster or various carcinomas, as well as any space-occupying lesions. As healthcare professionals, we may not possess the specialized expertise of a dermatologist, but we should be able to recognize when a skin lesion appears abnormal. Through extensive clinical experience, we become familiar with the appearance of normal skin, making it easier to identify deviations from the norm. If a skin lesion raises concerns or appears suspicious, it is prudent to refer the patient to a dermatologist, oncologist, or dermatologic oncologist for further evaluation. While these referrals may initially be met with resistance from some patients, it is our responsibility to advocate for their well-being and ensure that potential cancerous lesions receive appropriate attention and management. In such cases, we must prioritize the patient's health, even if it means protecting them from their own hesitance or reluctance. In regions with warmer climates, such as Southern California and Florida, the incidence of melanoma and basal cell carcinoma is higher. As healthcare providers, we must be vigilant and proactive in identifying potential skin cancers, as early detection and intervention can significantly improve patient outcomes. Age-related osteoporosis is a significant risk factor for compression fractures in the thoracic spine. The anterior wedging of the vertebral body during a compression fracture can result in an increased kyphotic curvature or exaggerated rounding of the upper back. When considering compression fractures, it is crucial to determine the patient's demographic profile. We typically expect to encounter compression fractures in certain populations, such as older adults with age-related osteoporosis. However, if the patient does not fall within this typical demographic, it raises questions about the underlying mechanism of injury. In cases of suspected compression fractures, a comprehensive diagnostic workup is warranted. This may include follow-up X-rays to monitor the progression or healing of the fractures, as well as an MRI of the affected area to evaluate the extent of the injury and potential involvement of surrounding structures. Additionally, bone density studies and laboratory tests can provide valuable insights into the patient's overall bone health and potential contributing factors. For young patients presenting with osteoporosis, it is essential to investigate their dietary history. This inquiry is crucial because certain eating disorders, such as anorexia nervosa and bulimia, can lead to nutritional deficiencies and impaired bone health, resulting in osteoporosis at a young age. Furthermore, if a young patient with osteoporosis is involved in athletics or physically demanding activities, it is prudent to explore their training history. Overtraining and excessive physical stress can suppress the endocrine system, leading to imbalances in hormones like testosterone, estrogen, and progesterone. This condition, known as low energy availability or relative energy deficiency in sports, RED-S, can contribute to the development of osteoporosis in young individuals. Moving on to another common condition, posture-related pain, or posture syndrome, often presents with upper and mid-thoracic pain resulting from poor posture, particularly in the workplace or environments with suboptimal ergonomics. Poor posture is frequently characterized by scapular protraction, a forward-tilted position of the shoulder blades. Patients with posture-related pain commonly exhibit weakness in the scapulothoracic retractor muscles, which are responsible for pulling the shoulder blades back, and tightness in the protractor muscles, which pull the shoulder blades forward. In cases of posture-related pain or posture syndrome, reliable imaging techniques may not yield significant findings. Electromyography, EMG, studies may reveal disuse atrophy, but are generally normal. It is important to note that while there is a recognized condition known as scapular syndrome, as described by Morgan, Burkhart, and Kibler in 2003, we will address this specific condition later in the term. A crucial aspect of the physical examination is distinguishing between a functional kyphosis, which is a curvature of the spine that can be straightened, and a fixed or structural kyphosis. This distinction can provide valuable insights into the underlying condition and guide appropriate interventions. To assess for a functional kyphosis, you can have the patient seated on the examination table. Position one hand on the thoracic spine and the other hand on the upper chest. By gently applying pressure, attempt to improve or reduce the kyphotic curvature. If the kyphosis can be straightened through this maneuver, it is considered a functional kyphosis, indicating that there is potential for improvement through targeted interventions and exercises. Before performing this assessment, it is essential to inform the patient about the procedure and obtain their consent. Additionally, exercise caution and mindfulness when placing your hands on the patient, ensuring their comfort and safety throughout the examination. In contrast to a functional kyphosis, a kyphosis associated with Scheuermann's disease, a structural deformity of the spine, will not improve or straighten with manual efforts to reduce the curvature. This distinction highlights the importance of a comprehensive assessment and understanding of the underlying pathology. Ankylosing spondylitis, AS, is an inflammatory condition that can affect the thoracic spine. Patients with AS typically present with complaints of stiffness in the thoracic, lumbar, and sacroiliac joint regions. They may point to the sacroiliac joint area as a site of discomfort. While AS is more common in males and individuals with a tall, thin build, it is important to recognize that this presentation is not universal. To aid in the diagnosis of AS, imaging studies such as X-rays of the sacroiliac joints, lumbar spine, and thoracic spine can be valuable. Additionally, laboratory tests like the HLA-B27 genetic marker and erythrocyte sedimentation rate, ESR, can provide further insights. Herpes zoster, commonly known as shingles, is a viral infection that can affect the thoracic region. Patients typically have a history of varicella zoster virus infection, either clinically apparent or subclinical. While the classic presentation of herpes zoster involves a unilateral, vesicular rash following a dermatomal distribution, it is important to note that the rash can also appear bilateral in some cases. The thorax is the most common site for shingles outbreaks, but other areas, such as the upper or lower extremities, or even the face, can be affected. In some cases, the herpes zoster outbreak may not present with the classic vesicular rash. Instead, it may manifest as a series of lesions resembling insect bites or even pimples, but all confined to a single dermatome. Postherpetic pain is a debilitating condition that can persist even after the shingles outbreak has resolved. This persistent pain can be significant and require specialized management. In cases of acute shingles outbreaks, it is advisable to refer the patient to their primary care physician for prompt initiation of antiviral medication and consideration of short-term corticosteroid therapy, if appropriate. However, it is important to note that the use of corticosteroids in the treatment of shingles is less common in current clinical practice. Patients experiencing an acute shingles outbreak pose a potential health hazard and should be advised to remain at home during this phase to avoid transmitting the virus to others. If you, as a healthcare provider, have not had chickenpox or received the varicella vaccine, it is prudent to avoid managing patients with active shingles outbreaks in an acute setting, as you may be at risk of contracting the virus. While not a thoracic spine pathology itself, pulmonary emboli can present with symptoms mimicking thoracic spine or paraspinal muscle spasms, knots, aching pain that progressively worsens. Patients often report shortness of breath as a primary complaint, which can be severe enough to prompt them to seek immediate medical attention or call emergency services. Pulmonary emboli can occur as a complication following various conditions or events that compromise venous return from the lower extremities. Major surgical procedures, prolonged immobilization, such as during long-haul flights, or any position that impairs venous return, can increase the risk of deep vein thrombosis, DVT, which can subsequently lead to pulmonary emboli. Other risk factors for pulmonary emboli include prolonged bed rest, trauma to the lower extremities, and, in some cases, the use of anabolic steroids, which can lead to an elevated red blood cell count and increased viscosity, predisposing individuals to thrombus formation. Pulmonary emboli are considered a medical emergency, and prompt action is warranted. If a pulmonary embolism is suspected, it is crucial to initiate the appropriate emergency protocols, which may involve contacting the patient's primary care physician or, in severe cases, activating emergency medical services, 911, for immediate evaluation and management. To illustrate the potential severity of pulmonary emboli, let's consider a recent high-profile case involving tennis superstar Serena Williams. Following foot surgery in Florida, Williams flew to New York. While there, she noticed swelling in her foot, ankle, and leg, prompting her to contact her doctor in Los Angeles. She was advised to return to Los Angeles immediately. However, during the flight, Williams developed mid-back pain and shortness of breath. Upon landing, she was taken to Cedars-Sinai Medical Center, where she was diagnosed with pulmonary emboli. The recovery process was arduous, and it took Williams a full year to regain her competitive form and return to play at a high level.